Welcome to a very special edition of the Monk and the Hedonist. Today we have back Dr. Forrest Tennant, really a pioneer and expert in the space of arachnoiditis. Really, this is a follow-up to our previous episode for the Monk and the Hedonist from March 18th, so episode number 7. So for those of you who are just kind of coming on for the first time, it would be really great if you listen to that episode first, because that gives you a really good, broad overview of arachnoiditis and some of the protocols that Dr. Tennant has developed. For this particular episode, we're just going to go over some questions that have arisen from the arachnoiditis community based on that episode. We'll just go through them one by one, and Dr. Tennant will be able to answer them. So Dr. Tennant, if you're ready, I'm going to dive in.
You bet.
Okay. So the very first question, and this comes from our previous episode and interview, you discussed your belief that the number one cause of arachnoiditis is really degenerative disc disease and protruding discs, and the inflammation that can arise from them. So if that's the case, why aren't we seeing more arachnoiditis if this is really coming from protruding discs? Or is there something more to it than that?
That's a very sophisticated question. And the answer is that I believe that when we say it's the protruding disc, practically everybody that you see today that has AA has the protruding discs. Now that I've said that, I actually believe that you've got to have a protruding disc plus another factor. Now, we know a couple of the factors, and there may be more of them. The protruding disc is just the thing that sort of shows up. But those people with the protruding disc, we know that there's another group, and that's the group of people who have one of the connective tissue collagen disorders of the Ehlers-Danlos type. Now, those people obviously have a collagen defect, and those people, if they develop a protruding disc, look out. They're really subject to going on and developing AA. Now, there's another group, and I didn't even want to bring it up, but since you ask, I can't be sure, but I've taken a lot of viral titers in people who have AA and protruding discs. And you start seeing very high titers in these people. And it's not just one virus. You see Coxsackie, you see Epstein-Barr, you see cytomegalic disease. So one has to start asking the question, did they slip the disc because they had a virus? Did they slip a disc and have some inflammation, and this gave them a milieu biologically where the virus could invade? So I have had this discussion before with a nurse practitioner who had done a lot of the tests for me, and we used to have some arguments. I started off saying, viruses couldn't be a problem here, and she kept saying, yes, they are, and I've kind of shifted over to her side. Now, obviously, you may have another autoimmune disease, because let's face it, there are millions of people who have protruding discs that don't develop AA. But in some people that have that protruding disc, it sets up a cascade of inflammation that goes on to, the inflammation spreads first to the arachnoid dural covering, maybe into the epidural space, into the cauda equina, and it takes a while, but eventually that cascade can give you AA. And so I think it is, when we say it's a protruding disc, seems to be the precursor. It's really got to be a protruding disc plus something else. And right now, some of the leading candidates are Ehlers-Danlos, viruses, autoimmune diseases, and there may be some others. But I think that today, in the past, as you know, we doctors take a protruding disc as being everyday life. I think today we want to look at those protruding disc patients differently. There's something maybe going on, and we've got to look at them a little different. So I think that's my message. And for anybody who is out there who has a protruding disc, I think you've got to be on some kind of a program and with the full knowledge that that could progress to something bad. So that's kind of where we're at. A great fertile ground for research.
Very interesting. Yeah, I did not know about the virus and that, viruses and them being a potential risk factor. That's very interesting. During the our last interview, you also talked about the necessity of epidural corticosteroid injections, and how corticosteroids cross the blood-brain barrier, and that you thought that injections have probably prevented arachnoiditis more than they've caused it. What are your views on epidural injections? Because it seems like there's a lot of confusion out there as to whether or not they're harmful in the management of arachnoiditis.
Yes, epidural corticosteroids. It's a little complex, but let me give you first off my views and how I think all this happened, and promises that have been unfulfilled by that technique. Now, first off, let me be real clear. If I had a protruding disc or a back problem, I personally wouldn't take an epidural injection. So that kind of gives you my bias right out front. Okay. Now let's go on from there. The reason I really don't like epidural injections is because they came along in the late 90s along with the long-acting corticosteroids, the long-acting opioids. And so pain practice changed overnight. Prior to that time, epidural injections with corticosteroids and long-acting opioids, intractable pain management, in other words, the management of the severe chronic pain patient was plodding along with new medical things being developed all the time, but it radically changed. Because the pitch was, these epidural injections obviate the need for physical therapy. They obviate the need for TENS units. They obviate needs for electromagnetic therapies, anti-inflammatory agents, and it was sold. And indeed, the early trials of giving epidural corticosteroids were wonderful. Patients felt better, they did well, and it literally founded a whole specialty called pain management. And it literally, birthed the basis of interventions. Now, unfortunately, like everything else, both the long-acting opioids and the epidural corticosteroid injections have run into troubles. And I know that the arachnoiditis community, if you want to call it that, is against epidural corticosteroid injections because it's caused a lot of adhesive arachnoiditis. And so where are we at with this? Now, the reason I made my statement is this. It's a risk-benefit. Both epidural injections for delivery or for anesthesia or for inflammation. Okay, it's a risk-benefit. In other words, let's say that 95% of epidural corticosteroid injections go well and there are no complications, but 5% go badly. Well, if you're in that 5%, it's a terrible procedure. And today you have that risk benefit. Now, where my gripe comes in is that these patients were not informed that they might develop a chronic cauda-equina syndrome or epidural fibrosis or adhesive arachnoiditis with that procedure. That procedure probably has prevented thousands of people from developing it, but it had complications. And so everybody wants a black and white answer, yes or no. Epidural corticosteroid injections look to me like they're here to stay, regardless of the controversies over labeling or the lawsuits or anything else. But it is a risk-benefit. And I think this. I think it's terribly wrong that patients got these injections and weren't informed of the risk. Okay. Now, I personally wouldn't take the risk, and I don't recommend it. I know a lot of physicians who would disagree with that statement. They're getting great results. I know physicians who have done thousands of epidurals and had no complications. And so they look to me like they're here to stay. And I think the arachnoiditis community needs to understand it is a risk. There should be informed consent. A lot of us wouldn't take them. And but let me just give you my first real gripe. Prior to the long-acting opioids and the epidural corticosteroid injections, we had a pain practice that was plodding along. One of the questions coming up is, well, what about doctors who won't use corticosteroids? It's amazing. Doctors after the late 90s were taught to give a bolus of methylprednisolone in the epidural space, but are scared to give 2 milligrams of methylprednisolone 2 days a week. And what it did, it wiped out the treatment room. Now, let me just say my gripe about medical practice today. We went too fast with our technology. We gave up the treatment room. You go into a general practitioner's room today in any town in America and ask a general practitioner or a nurse practitioner, do you have a treatment room? Now, the old treatment room had some hot packs, we had some braces, we had some kind of electromagnetic device, we gave some shots. Those are gone. Because today, the standard is you walk into a general practitioner's office, you got a bad back, you had a work injury, you're sent for an epidural corticosteroid injection as first-line treatment. We gave up the World Health Organization 3-step analgesic ladder, which said try non-medical means first. Try exercise, try diet, try stretching, try a local corticosteroid injection, not an epidural injection. So those, I know it's not what people want to hear. They want to hear, let's stop them. It caused problems. You can't do that. It's a risk-benefit ratio. And you do have to face the fact that there are physicians out there who've had great success with those injections. They've lobbied to keep them alive. They're doing them daily, and they've had great results. But the least we can do is inform people that there is a risk. So I know that that's a little complex, and it sounds like I'm on a soapbox, and I'm as unhappy about these things as other people, maybe for different reasons. But I think it changed medicine, and it went too fast.
Yeah, it is a complicated question with a complicated answer, indeed. My father was an anesthesiologist and probably did thousands of these throughout his career. And yet he developed arachnoiditis by getting one on his own back. So it's a really complicated answer. So I appreciate that. As we're talking about steroids, and how necessary they are in the management of arachnoiditis because they cross the blood-brain barrier. Yet so many arachnoiditis patients are having difficulty with their physicians having reluctance to prescribe corticosteroids. If you can take a moment to specifically talk to a physician who might encounter a patient who has arachnoiditis, what would you tell them?
I would tell them, first off, only do things you're comfortable with. And if you start something new, try a little bit before you try a lot. Now, my generation of physicians is comfortable with corticosteroids. Why? We grew up in the days before we had biologics. The advent of biologics for rheumatoid arthritis and for lupus and scleroderma and the other collagen or autoimmune diseases what it did, it really eliminated training in medical school and in residencies to use corticosteroids. Now, when I was a resident, my head of medicine carried in his hip pocket a syringe with a little xylocaine and a couple of cc's of a corticosteroid. In every other room, we gave corticoids to somebody, okay? Now, today, you would never see that. So, and a lot of us, again, were military trained, or in the Army or the Navy, and so we used corticosteroids liberally and knew how to use them. Today's doctors, it's like putting your toe in the water. They weren't taught to use them. They're afraid of them, and they should be afraid of them. So you can't, when a doctor tells me they're afraid of them, they don't want to use them, I understand fully. It's new for them. And however, here is my advice. For the doctor who is worried about it and hasn't had either taken the training or doesn't know and hasn't got the time to go read about it and study it or go to a seminar on it, start easy, start safe. How about a one-time-a-month injection? Have the patient come in your office, put a cc of dexamethasone or methylprednisolone in a syringe and give it to them. You know that's going to be safe. It's not going to hurt anybody. And here's the other thing for the patients. One of the better things that FDA has done in recent years is allow the adrenal cortex, adrenal whole gland supplements to be on the commercial market. They're quite safe, and they were taken off for a while, but they can at least help substitute. They're safe, and they get your foot in the water. And so when doctors don't want to do it, I fully understand. The other thing that they don't understand, you're trying to have a doctor who wasn't trained to use these things because of the advent of biologics and the potent anti-inflammatories and other procedures. And before that doctor or nurse practitioner can bring themselves up to speed, they're going to have to walk before they run. And so you want to approach it from that basis. But the other thing that's a little sophisticated. For years, prednisone has been the popular drug for physicians. Unfortunately, prednisone doesn't work in adhesive arachnoiditis all the time. Apparently, it doesn't quite get through the blood-brain barrier or the spinal cord barrier as good as methylprednisolone or dexamethasone. And so you have something like 12 or 13 commercial corticosteroid products. And those two seem to be the ones that will get past the blood-brain barrier and seem to be the best. But again, my final word is on this. We talk about the term low-dose naltrexone. Let's also talk about the term low-dose ketorolac and low-dose corticosteroids. Corticosteroids in AA are probably going to have to be used in a lot of people for years, maybe a lifetime. Therefore, you don't want to use them daily unless you just have to. You want to use them intermittently at a low dose. Now, you don't get the complications if you're taking, let's say, 0.5 milligram of dexamethasone twice a week, or let's say 2 or 4 milligrams of methylprednisolone 2 or 3 times a week. But above all, you want to skip days with corticosteroids unless somebody's just got to have them. And if you got to take them daily, there's going to be complications. No question about it. You're going to get pituitary suppression, osteoporosis, all the moon face, you're going to get it all. And so with long-term lifetime management today of this disease, we've got to be thinking in terms of low intermittent dosages over a long period. And that's where we're at this day. Now, we might get a break. I happen to know that there are some scientists who are interested in developing biologics for this disease. Let's pray and hope it comes true. We might have a stem cell therapy that comes through. We may have a polypeptide therapy. We've got a lot of people trying new things. I'm delighted to see it. We need it. But in the meantime, we're going to have to rely on corticosteroids. And again, I hate to apologize for all you young folks, but in my generation, we had to use for rheumatoid arthritis gold. We didn't have prednisone. We had to use plain cortisone. And so in some ways, we have to go back to those old days in this disease because to us, it's a new disease. But it can be done and will have to be done. But again, for doctors out there and patients, start with maybe a one-time-a-month shot. Work with your doctors. Bring them some information. You got to remember, today's doctor may have to see a lot of patients, doesn't have a lot of time. Continuing education for physicians, dadgum, they're falling through the roof. With COVID and everything else, you just don't have the seminars or the monthly talks for doctors. I talk to doctors all the time that they haven't been able to go to a continuing education forum for 2 years. So we're all in this together.
Thank you. That was a great explanation. For patients who may have some kind of medical contraindication to steroids, and I know you've hit on this a little bit, but are there any other viable alternatives that are, reasonably effective?
Yes, I'm not saying everybody's going to have corticosteroids. But I will say this, based on my experience, and I hope it changes, but based on where I'm at today, there have been 3 compounds that an AA patient better have. 2 of the 3 probably. One's low-dose naltrexone, the other's ketorolac, and the other's a corticosteroid. Now, when you get past those 3, I'm not sure what's your success going to be. I mean, some people do well with a diclofenac or an indomethacin or a nandrolone or a lot of the non-prescription agents like a PEA or what have you. However, the three agents that really have stuck, if you will, really seem to get us somewhere is either low-dose naltrexone, ketorolac, and one of the corticosteroids. Now, if you're going to not take a corticosteroid, you better certainly try to take some ketorolac, because that's the one anti-inflammatory that gets in the spinal fluid, is potent enough that penetrate into the spinal fluid and somehow attach on to your caudoequine nerve roots and get you some relief. So I like to see people take 2 out of those 3 compounds as a good start. And so that's kind of where I'm at. But again, when I heard somebody say they can't take a corticosteroid, I think what they're really saying is they've been given too many, too often of the wrong kind. And practically anybody can tolerate a once-a-month shot of a corticosteroid. You just can't take it very often. I mean, you've got some people with severe osteoporosis, or you've got some other kind of contraindication. And so you don't have to take them on a regular basis. But I know it sounds funny, but even a once-a-month corticosteroid injection will help.
That's great. That's very practical advice. Another topic that came up from our last conversation was hormonal supplements, such as DHEA and progesterone. So the question is, do we need to have those hormone levels tested regularly? Because that seemed to have caused some confusion.
This is an excellent question. Let me put it this way. We're talking here about health plan coverage and finances. We're not talking about clinical optimism. Optimally, a person with AA should be having a hormone panel every quarter. I mean, you ought to take your cortisol, your pregnenolone, your testosterone, probably estrogen and progesterone and DHE, about a little panel of around a half a dozen hormones, if you can financially attain them. But today, laboratories, and of course the cost has come way down, but it's still, a lot of your insurance plans aren't going to cover those compounds. They're probably too expensive to pay yourself. So in patients who can't get the hormone test, but again, if you can get the test, that's great, do it. And then you can monitor or titrate your therapy to where you get normal blood levels. But if you can't get the hormone levels, you're not going to hurt yourself by going down to the health food store and getting some DHEA or pregnenolone. Those two are non-prescription. They've been proven to be extremely safe, even at very high dosages. And you can start those two and get some effects. Let me just say this, when you do start something like a hormone from the health food store or on the internet, get them wherever you want. One brand is about as good as the other as far as I can tell. Most patients that take DHEA find that it's quite effective at a dose of around 200 milligrams a day, but some do well at 50. So somewhere between 50 and 200 milligrams a day, you're not going to hurt yourself. Pregnenolone has about the same dosages, and you can take them alternate days. You don't have to take hormones every day of the week either. In fact, one of the issues that I really want to emphasize to everybody is that you've got to be on what I call an anabolic program. And I'm hoping every listener here remembers that term, anabolic program. And that's where the hormones come in. Now, anabolic is Latin or Greek for bolic means growth, ana means before growth. Catabolic means cata is deterioration. That means a declining growth. And if you're not careful with a disease like arachnoiditis, you go into a catabolic state, meaning your tissue is fundamentally declining all the time. And those of you who have Ehlers-Danlos syndrome, you're genetically programmed to deteriorate your collagen and your tissues. You've got to be on something to rebuild it, and you've got to do that daily with your diet, your exercise, and your supplements. So if you can get the hormone levels, do it. Let me just say a couple other things about hormones. The thyroid, some patients are going to have the autoimmune manifestations of arachnoiditis and have Hashimoto's disease. You may need to be taking thyroid. You're going to have others of you who are going to have intractable pain. And if you take a prolactin level, that's almost diagnostic of the intractable pain syndrome. Prolactin goes up. And so you can use blood testing for hormones, but don't let the fact that you can't get it due to financial reasons, or a doctor won't order it, or some other reason, don't let that hold you back. You can get started with some of these over-the-counter supplements and do it safely and cheaply.
Dr. Tennant, what about patients who, as this is more specific to men, but as men age, they may develop BPH, their prostate may be getting enlarged, or they may have risk factors for even prostate cancer. So when you're taking things like DHEA, that does increase your testosterone levels. So, do you still consider DHEA to be safe in that type of patient population?
Yes, I do. As long as you keep the dose down under around 200 or 300 milligrams a day. Let me tell you the problem with DHEA. It doesn't convert enough to testosterone or to estradiol. Only a fraction of it does convert. And so our problem has been that we can't take enough DHEA as a substitute for testosterone and estradiol. And let me just say something before I forget it. I remember the days when most general practitioners in America would have any number of women in their community who were postmenopausal who came into their clinic, their office once a month for an estrogen shot. I truly believe we had less pain problems in those days, because I think the estradiol is very protective. When you study the metabolism of estrogen on the spinal cord, it's profound, and so is testosterone. So I think that everybody with AA is going to have to kind of pick their therapy that's going to work pretty good. But the old-fashioned estrogen and testosterone shots are quite good. The fear of BPH and cancer with these hormones, I think, is way overstated, because we're not getting into the high dosages. For example, they've scared every woman in the country from ever taking Premarin, but they got to remember that those Premarin studies, they were done in people who didn't take estrogen blood levels. They gave it every day. They gave it to high-risk patients, and they've scared everybody from taking estrogen supplements or a shot of estrogen. And I think that's very unfortunate, because, again, hormones, just remember this about hormone use for therapy. Again, it goes right back to what we said about corticosteroids, which are also, cortisone is also a hormone. Low dose, intermittent, not daily, not high dose. You take them low dose, intermittently, and that way you avoid the complications.
Excellent. The next question has to do with surgery. So many patients with arachnoiditis suffer from conditions that may require surgery, and some of our patients are being advised that they have to have surgery done. The general consensus in a lot of these AA groups, however, is that you cannot have surgery without fear of your arachnoiditis progressing. Is that a realistic fear?
The answer is yes, but there's another part to that, and that is sometimes you just have to take the surgery. I have sent many patients to the neurosurgeon, and the patient didn't want to go because they were afraid of this. But I could take one look at their x-rays and do their physical exam and see, we may not like the risk of the surgery. And indeed, you've got that risk, but on the other hand, if you don't get the surgery, you are going to have problems. So the idea that we're going to be able to eliminate all neurosurgery or all orthopedic surgery is a misplaced fear. There comes a time when you just have to go do it. And for example, I've gotten awfully good at looking at a lateral view of an MRI, and if that disc is just cutting off the spinal cord, you've got to go have surgery. I mean, if that spine is just too unstable, or that Tarloff cyst is just getting too big, you just have to have the surgery. So, and I think this, I've got to give, from my point of view, compared to where we were 3 and 5 years ago, I'm so pleased and proud of the medical profession. I see surgery and the surgeons now taking on the whole mantle of arachnoiditis, and they didn't even used to discuss it. And it has a risk, but if you got to have the neurosurgery, you're going to have it. Getting a second opinion is always a good idea, and but nevertheless, we're not going to be able to avoid all surgery, even in patients who may already have arachnoiditis.
Great. Historically, we know that myelograms were a major issue and risk factor for arachnoiditis. So a question that came in is, what's your advice on having a CT myelogram now if you have arachnoiditis or suspect that you may have it?
Today, I mean, I'm very partial to the contrast MRI, either with the dye or with the new Tesla devices. These are great advances, and you can really see what's going on. If we didn't have the contrast MRI, I wouldn't be standing here today. That's given us the ability to see into that spinal canal and know what's going on, and the ability to do this research. I don't like myelograms in the sense that you've got to inject dye perhaps into the spinal canal, but again, there may be conditions in which you're going to have to do it. I confess that I'm not an expert in myelograms and exactly why you would do a myelogram compared to an MRI. So I'm afraid I'm going to have to refer you to your radiologist as to whether the myelogram's got to be the technique to be used. I have seen myelograms that have been excellently done, but no, you don't like to see anything injected into the spinal fluid. But sometimes, again, that's something that may have to be done.
Next question. Can the inflammation that you see in arachnoiditis travel up the spine to affect other areas such as the thoracic, the cervical, spines, the arm, or even the brain?
Of all the questions you ask, this is what I didn't really want. There are people who swear that they have had lumbar sacral arachnoiditis, and the next thing you know, they've got it in their neck. And you know something? It does appear that way on the MRIs. Now, how did it get there? And can it travel? Well, arachnoiditis itself is a mass of adhesions and nerve roots embedded in a ball. So that doesn't travel, but I will have to say it does raise a question. Is it possible, and looking at these slip discs now, is it possible that inflammation is like an ember from a fire? Can a piece of inflammation float through the bloodstream or lymph or the spinal fluid and land somewhere and sort of start inflammation? I'm asking that question. I don't know the answer. It is possible that people with adhesive arachnoiditis develop an autoimmune disorder that starts in the lumbar section and then it goes to the neck. The other thing that I think happens that makes people think it's migraine is that they have Ehlers-Danlos syndromes or one of the syndromes, and they just simply have had the arachnoid dural lining break down in a second area. So whether it actually spreads or not, I don't know. But we do have people today who may start off with a cervical arachnoiditis and then can go and start into having a lumbar sacral adhesive arachnoiditis. So we do see that, but the cause of it is not certain. Okay? But I don't know that if it can migrate, because the only way it can migrate would be to have inflammatory particles, if you will, break off and float up the spinal fluid. We have to do that. But I don't know that that's biologically ever been documented or could happen.
Very interesting. The next question has to do with pain pumps and spinal cord stimulators in lieu of pain medication. What are your thoughts on spinal cord stimulators and pumps? And can you talk a little bit about the potential pros and cons about them?
Yes, the spinal cord stimulators and pumps are a necessity in some cases. I send people to get them every once in a while, and there have been wonderful technological advances. Now that I've said that, most of the people who are being asked to get these things have not gotten themselves on a good three-component medical program. And one has to remember that that spinal cord stimulator is an adjunct, or should be an adjunct, to a program that's in place that doesn't work totally. These stimulators and the pumps were never intended and aren't intended to be a substitute for a solid ambulatory program. In other words, let me put it this way. You got to have, in my opinion, you've got to have a program, a protocol to deal with arachnoiditis. Arachnoiditis is not a forgiving disease. If you leave out an element, you're going to pay for it. You got to be on the right diet and the right supplements. You've got to be on spinal fluid exercise and other oxygen giving exercises, stretching exercises. You're going to have to be on medication to suppress inflammation. You got to be on medications to build tissue. You got to be on one to have pain control, because once you get that stimulator and the intrathecal pump, one or the other, it's not a substitute for these other things. It's to be in addition to a basic program that is not working. So I send people to get the stimulators all the time, but there are people who are not making it with a basic program. Because even if you have the stimulator or the intrathecal pump, you're still going to have to be on anti-inflammatory agents. You're still going to have to be on hormones, exercises. It is not a substitute. So that's why I harp on the fact that you got to be on a comprehensive program for adhesive arachnoiditis. You can't leave out an element, and you can't expect. My gripe is people think, well, if I just get a stimulator, or I get stem therapy, or a polypeptide therapy, or I try this new thing I heard about, I won't have to take all these medicines. I don't have to do these exercises. I don't have to follow this diet, and it won't work because because they're not substitutes. And I think that's where people are going wrong. And if a physician does say you should do that, and I don't think the physicians do that. I think they go to a pain specialist, and the pain specialist says, look, I can offer this. I can't offer you the medical component. Now, let me just say another thing about this. In adhesive arachnoiditis, and incidentally, Bobby, I'm so glad you're starting to take patients. I'm hearing from doctors all over the country who are starting to take patients. This thing is now common enough that every community is going to have doctors to take this problem. Adhesive arachnoiditis is a medical problem. It has gone into like rheumatoid arthritis. We're going to have to treat it medically in every community. And so once your medical treatment doesn't do well, we better call in the stimulators, call in the intrathecal pumps. I'll be honest about it. I spend more time trying to tell patients and doctors to use the stimulator and the pumps than I do telling them not to use it, because there's a terrible cost involved. And insurance companies don't want to pay for it. They're very expensive. And so therefore, everybody's got to realize, don't think of these new high-powered technical devices as being a substitute for a solid dietary, physical measures, medical approach to treating this disease. You can't leave out anything with this disease. It'll get you. You leave out your diet, you leave out your hormones, you leave out your corticosteroids, you leave out your anti-inflammatories, that disease is going to bite you. It will progress. It does not go away on its own. And so I want people to really realize stimulators and infusion pumps are in people who fail our medical treatments.
Thank you for explaining that so well. And yeah, I think the take home point is the pain management part of this is just one component of the entire comprehensive protocol that you're talking about, which includes lifestyle, management and exercise and diet and modulation of neuroinflammation and regeneration of your spinal cord. And So there's so many different components that all have to be addressed outside of just the pain.
Absolutely. Well said. Absolutely. And I think that's just a message from the pulpit that you won't see me give up. It has to be there.
As I've started to also see arachnoiditis patients, there are some common overlaps, from my primary specialty, which is treating cancer patients. One of the questions, of course, that comes up in both of these populations is, can I be cured? Can I be cured of this diagnosis? So when it comes to arachnoiditis, can it be stopped and reversed if caught early enough? And what about those patients that have severe arachnoiditis? Do they have any hope in successfully treating their symptoms or stopping the progression?
The answer is yes to both questions. If we can catch the disease early enough, if we can catch it at the caudo-equina stage, or the inflammation at the caudo-equina stage or the protruding disc stage, I've got patients that are totally off all medications and for all practical purposes have cured themselves. And so that's one of our messages. Get started early, okay? If that MRI comes back and it doesn't show adhesions and doesn't show nerve clumping, but may show a little something that indicates inflammation, you get a CRP, an ESR, you get started on anti-inflammatory treatment. The answer is yes. We've got a lot of people now who are into treatment, and they are either almost curing themselves or bringing their symptoms down to where they don't have to go on to opioids or into the catastrophic areas. Now, unfortunately, we have a lot of people who nobody knew what they had. They developed the disease 5, 10, 20 years ago. And they've been put on high dose opioids, they've been put on stimulators, they've been put on all kinds of things. In other words, they and their families and their doctors did the best they knew how. But unfortunately, they're catastrophic. Some are bed-bound, wheelchair-bound. Now, do we have any hope for them? And the answer is yes. I'm hearing from people all the time that are trying new things. And let me emphasize something. Keep trying new things. Just be on the basics, but keep trying new things. For example, I've got a wonderful letter about a physician who has terrible arachnoiditis, and she is out of bed walking around by taking boron. I've got another patient who's been bedbound for years, who's out of bed now, and took one of the intrathecal polypeptides or stem cell type therapy. So we're starting to see occasional people with new things, but I don't care at what stage you are. If you're bedbound, you're in a wheelchair, you're on high dose opioids, stay with it. Stay with whatever is working for you. Try to get a balanced program and try new things. I don't buy this argument that somebody's just got to give up and can't get better. Okay, so you're in a wheelchair or so you're bedbound. A lot of people still have a good life. The good Lord hasn't taken you yet, so He wants you here for some reason. Develop some kind of a life and get some kind of good pain treatment. Keep studying. Keep finding out what we can do. So I don't like this idea that we give up hope or there's nothing we can do. One of my pet peeves is when I hear from a patient that says, I've been to my doctors, I've been to my pain specialist, I've been to my endocrinologist, and they say there's nothing that can be done. I totally disagree with that. We can do something for everybody. I think we should do something for everybody. And like I say, all of us aren't going to leave this earth in good condition. We're all got to go, and so you have to kind of be a little philosophical about it, a little spiritual about it, and that is, if this is your disease, you do the best with it you can, but let's keep working to help everybody that has it. I don't buy the idea of giving up. Okay.
Dr. Tennant, that's such a powerful message, and I think someone who has seen as many patients with arachnoiditis as you, still saying that patients have hope and that many of these patients can be reversed if caught early and or even successfully treated, even if they have severe diseases. I think that's very encouraging, and that should bring hope to a lot of these patients. What about patients who are having a hard time getting their physicians to take their arachnoiditis symptoms and concerns seriously? What would you say to these patients as to how they can approach their doctor? Is there any literature that you would recommend that they take with them?
The answer to that is, yes. Now, in my career, for example, I was one of the founding members of the Lupus Society, and nobody believed in lupus. Then came along fibromyalgia, and nobody believed in fibromyalgia. And I could probably come up with half a dozen other diseases that nobody believed in, for example, dementia. So modern medicine, a new condition, always goes through a cycle of a few innovative patients, families, and physicians identify something. And then the medical profession kind of instinctively, and I'm no better than anybody else, denies that that disease exists. Because doctors are busy. They're terribly busy, and they're taught to do certain things, and they teach themselves to do certain things. So then there's sort of a denial phase. And then there's sort of the acceptance phase, but I'll accept it, but do I have to treat it? And so the fourth phase is, I got to recognize it, I've got to accept it, and I've got to treat it. Well, we're not to number 4 yet for everybody, but we're moving everybody down the spectrum. And so just keep, my answer is, putting it just very bluntly, keep hammering away. Okay. We've got to bring everybody to the carpet here and just keep taking them information, things from the websites, brochures, articles, whatever you can find, and keep laying it on the doctor's desk, okay? And I don't think there's a doctor alive who today doesn't kind of instinctively appreciate it when the patient does bring stuff to them, because I want to emphasize something. If I had, the health system has, I don't want to say it's degenerated, but it's been cut up. Now, when I was a young doctor, if there was an article published in the Journal of the American Medical Association, everybody in the world knew about it. We knew it and read it, and everybody accepted it. Today, there are hundreds of journals, associations. Many states anymore, their universities don't even do postgraduate education for practicing doctors. The federal government has essentially banned pharmaceutical companies and medical device companies from putting on continuing education. Hospitals feel it's a loss leader. They don't want to do continuing education. So the doctor's out there on their own. And he's a small businessman usually who has got to get his information from somewhere. And so I think deep down, I don't know many doctors who aren't pretty appreciative when patients bring in brochures, and particularly if their family comes with them and says, "Doctor, my family has this, can you help us?" They may give you a little guff at first, they may resist it at first, but don't give up. We've all got to be advocates on this and bring everybody knowledge about this disease. And I'll just say one other thing. This disease, I hate to say it's a fascinating disease and it's very interesting, but I'm talking doctorish now, or scientifically. It's very interesting to me about how the inflammation occurs and the nerve roots get clumped and how we entrap nerves and how we're going to untrap them and get people doing things. I find it very scientifically very interesting. And worst thing that can happen to a patient is to have the doctor say you have an interesting case because you need a case that needs treated. But yeah, I think you get what I mean. But no, don't give up on it. But I will give you a practical message. Every patient with AA needs to find out what their primary care doctor will prescribe. Okay? If that doctor will prescribe some tramadol, he'll prescribe some estradiol, he'll prescribe some, ketorolac or whatever. You got to find out what he will do and then fill in. 80 to 90% of your program, of an effective program, is done without a doctor's prescription. Remember that. Don't be paralyzed because you got a doctor who won't quite do what you think's on the protocol. You can get started with your diets, your exercises, your spinal fluid exercises, your non-prescription supplements and drugs. And 80 to 90% of a good program is not on your doctor's prescription pad. It's what you can do with your family. And now you may have to study some. Once you get a disease like AA, you got to go back to school. You got to start reading and studying, talking to people, joining groups. You've got to start studying and start doing stuff on your own. You can't be waiting for your doctor to save you. You've got to do it. And that's one of my messages today. Don't expect your doctor to guide you on this. You need to guide yourself. Medicine has changed. Your doctor probably aren't too dadgum busy. There's a lot of technical things he's got to do. And so remember, you've got the disease, not your doctor.
One of the great things about technology is, compared to 20, 30 years ago, is the fact that there are so many more resources out there that patients can access information now. They can be a part of online communities, such as these Facebook communities. So at least there are ways now in which AA patients can connect with each other and get good information. And I've been always impressed with how self-educated a lot of these AA patients have become.
I think it's just great, and that's your savior. Understanding the disease, understanding the anatomy of your spinal canal and your nerve roots, and you got to learn a new vocabulary, and you've got to learn agents. In fact, one of my soapboxes today is I want everybody to know if you're taking something by shot or by mouth, what is its purpose? Not the name of it, not its dose. What's the purpose of this thing you're taking? Why are you taking vitamin C? I recommend vitamin C for everybody every day, but I want to know why you're taking it to build tissue. Why are you taking Ketorolac? You're taking Ketorolac to suppress spinal canal inflammation. So you want to know why you're taking drugs, what's its purpose. And again, this is kind of new for people who have a terrible disease, but that's what you have to do today. I don't see a way out except for patients to get very educated about their diabetes or their heart failure or the EDS, and particularly AA. You've got to go back to school and learn about it. I don't think you have a choice. You cannot depend on some big university center or some high-powered specialist to take care of you. It's going to have to be in your community, and you're going to have to learn enough to kind of take care of yourself.
Another question. What do you feel about stem cell therapy? And do you believe it's a viable option for those who can afford it?
I am all for people trying the stem cell therapies. Let me see if I can put this in perspective. It's a little bit like the spinal cord stimulators. You first need to be on a basic good program. Okay, now once you're on a good program, you've got pain medications, you've got tissue growing agents, you're suppressing inflammation, you're doing your spinal fluid exercises every day, you've got some kind of electromagnetic device you're using. You put a good program in place. Then search out stem cell therapy. Polypeptides are kind of being used right now. There's some amniotic fluid things being used. There's nothing wrong with trying these experimental things. There's going to be, in my opinion, some kind of a stem cell type therapy, if you will, that's going to work pretty well. I know of some different techniques being used at this time. There's nothing that's been consistent yet. I hate to see people spend a lot of money for something that's too darn experimental, but put a good program in place. Don't buy any line that this stem cell treatment or anything else is going to solve your problem. Get a program in place and try it. You've got nothing, you don't have anything to lose. Most of the stem cell therapies are past the point of being toxic or having a lot of side effects, so they're worth trying. And if people don't try them, we'll never figure out which ones are best. So yeah, I support it, but I only support it after you've been on a good basic program. The stem cell therapy is not going to be curative. What it'll do, and let me give you another therapy that I kind of like these days, and that's infusions. Stem cell therapy, and let me talk about infusions in the same breath. These things may bring you into a remission or close to a remission, give you a lot of comfort for a few months, and then you've got to repeat the test or repeat the therapy. Nothing wrong with that. And so that's one of the things you can do. I'm convinced that these stem cell therapies are going to have that same kind of treatment effect. For example, you've got a lot of people today with AA who will get one of the infusions. Now, the infusions being used are lidocaine, NAD, vitamin C, ketamine. I may have left one out or two, but there's nothing wrong with trying these things either. And some people will find that you're going to get some good relief that'll stay there for a few months or a few weeks. Again, you can give them a try, but don't let these things be a substitute for the basic protocol.
Thank you. And our very last question has to do with AA and how it impacts CSF flow. And it seems like there's been a lot of confusion within the AA groups regarding this, specifically because some of their physicians don't agree that there could be CSF flow blockage from AA. Can you talk about that a little bit more, and also talk about how some medications like acetazolamide can help with that?
First off, we're not 100% certain how this works. Let me start with a couple of basics. The spinal fluid is made in the midbrain, and it's made, and you totally turn over the spinal fluid in your whole body every 4 to 6 hours. So you make new spinal fluid every 4 to 6 hours. And the spinal fluid itself is in a very small pipe. And you want to think of the spinal canal as a pipe. And it's kind of amazing. It's made in the brain, the spinal fluid, and it goes straight down the spinal column and then turns around and comes back up. And there's no pump as far as we can see. Maybe the heart beating forces it to move. But there have been studies, particularly in the neck, where the gradient across this very small pipe with an arachnoiditis mass does interfere with the flow. And so you get patients with arachnoiditis who have blurred vision, tinnitus, it's ringing in the ears, headaches, and dizziness, things like that. And people think they have a spinal fluid leak. Well, most of the time they don't. There is no question that in the lower lumbar spinal cord area, when you develop adhesive arachnoiditis, you can fundamentally put a mass inside this pipe, because that's what adhesive arachnoiditis is. It's a clump of nerves made of adhesions, scarring, inflammation, nerve roots. It's a ball, it's a mass. And it does interfere with spinal fluid flow. Now, why acetazolamide works, again, that's really a little bit uncertain. It's thought that it lowers spinal fluid pressure. And some people can take a small dose, 125 to 150 milligrams of acetazolamide, and feel a lot better. So we assume it's dropping pressure a little bit. And that's just like in the eye. But you do get some kind of interference with the flow. Now, I can't tell you whether the symptoms are caused by slowing down of the fluid flow or making it pulsate or do something abnormal. We don't know. But when you do get these symptoms, trying PEA, palmitoy ethanolamide, has recently been shown to at least regulate some fluid in the eye. That and acetazolamide are worth trying, but we really don't quite know what's going on with spinal fluid. It's really an area that very few people have done research on it. I'm sure I'm like most physicians, I'd never thought about spinal fluid flow until 3 or 4 years ago. And so I'm just learning about it, and I think all the other physicians are, so we got a lot of questions. So if somebody disagrees with me, I may disagree with me too. I'm not just certain. But we do know that spinal fluid flow is important. Now, let me just say one thing about it. Spinal fluid has some functions that just can't be overlooked. First off, it carries your nutrients right from your diet into the spinal fluid and bathes it. I mean, it carries in vitamins and minerals and enzymes just like blood does. It also flushes the system. And so between nutrition and flushing, the good Lord has us turn over and make new spinal fluid every 4 to 6 hours. So it's got some functions that the body considers absolutely essential. So, and now that I've said that, I think there are too many people who think they have leaks when they don't. and you can try some acetazolamide, but I don't have a good answer for a lot of the people I see that I think have symptoms related to spinal fluid flow, but I really don't know the cause of it. I'm trying to investigate it and learn what I can, and I'm take anybody's knowledge. So anybody who's got some good theories, let's hear them. And we need some of your engineers, medical engineers, and some of your basic scientists to try to give us some answers on this, because we clinicians, I'm not quite sure how we study this, but it is a problem. Unknown answers.
Dr. Tennant, thank you so much for your time and answering some of these complicated questions. I'm sure the arachnoiditis groups and Facebook groups are going to really appreciate this follow-up episode. Before we get off, I also want to thank Lori Verton. She's the president of the Arachnoiditis and Chronic Meningitis Collaborative Research Network. She was the one that really kind of encouraged us to do this follow-up episode, and she put these questions together. So thank you, Lori. If you enjoyed this episode, please subscribe to our podcast and also our YouTube channel, where we'll continue to bring you information like this. And Dr. Tennant, is there another way patients can find you or get information from you if they're not already doing that?
Our reward is if you go out there and keep telling your local doctors to get with it. That'll be the reward we're really looking for. But we do have a website, and we do put out a bulletin about once a week to try to get people updated. One of the things I'm trying to do is something new, and that is try to give people with this disease an update each week to remind them how to take care of themselves, bring them anything new, try to give them a boost in spirit. So, and that's all free. Somebody can make donations if they wish to, but I'm pleased to say that raising a little money for this good cause has not been all that difficult. But anyway, we do have a website. We do put out a bulletin, which I'd recommend everybody who has this condition, or any physician or nurse practitioner or naturopath who wants to try to treat it. We try to keep everybody apprised of what's going on. And I, for one, plan on continuing this effort until I'm pretty confident that we've got physicians and practitioners in every community in the modern world willing and able to see these patients.
Thank you again, Dr. Tennant. Thanks for being a beacon of hope for so many patients who have this condition, and we appreciate your time. Thank you.
My pleasure. Good luck.